Welcome to our guide to the Bishop score. We're going to make this super simple, clear, and really easy to remember for your exams. The goal here is to get you feeling confident, whether you're facing a written paper or a hands-on OSCE.
Okay, so here's how we're going to tackle this. First up, we'll get straight to the point. What is the Bishop score? Then we're going to break down the 5 key components you absolutely need to know. From there, we'll see how to actually score everything, what that final number really tells you, and, this is the crucial part, how to turn that score into a real-life clinical action. Ready? Let's jump in.
So first things first, what is the score all about, and why is it such a big deal in obstetrics? Let's really nail down its core purpose.
At its very heart, the Bishop score, which, by the way, you might also hear called the cervical favorability score, is basically a clinical report card. It gives us a standardized way to check out the cervix and figure out just how ready it is for labor to be induced.
You know, you can almost think of it like a weather forecast for labor. It helps us answer that one really important question before starting an induction. How likely is this to work? It's all about predicting the chances of a successful vaginal delivery and making a solid plan right from the start.
Now, to come up with that score, we need to look at 5 specific things. Let's break down the building blocks, exactly what you'll be assessing during an exam.
So these are the big 5. And listen, for your exams, you're going to want a way to remember these, right? Here's a great little mnemonic. Doctors examine cervical progress smoothly. So that's dilatation, effacement, consistency, position, and station. Seriously, get these 5 down and you're well on your way to nailing the Bishop score.
Okay, so we know the 5 things to look for. Now for the fun part, turning our observations into actual points. This is where it all comes together into a concrete score.
First one up is dilation. It's pretty simple. It's just how open the cervix is. If it's closed, that's a 0. As it starts to open up, the score climbs, maxing out at 3 points when you get to 5 centimeters or more. Next is effacement, which is just a fancy word for the thinning of the cervix. Picture the cervix getting shorter and thinner to get ready for birth. A thick, long cervix scores a 0, but once it's really thinned out, like 80% or more, it gets to maximum 3 points. All right, component number 3 is consistency. This is all about what the cervix feels like. And there's a fantastic, super simple trick to remember this. Just use your own face. If the cervix feels firm, like the tip of your nose, that's a score of 0. If it's kind of in the middle, like your chin, you give it a 1. And if it's soft and ready, like your earlobe, that's the most favorable, and it gets the full 2 points. Simple, right? Then we have position. And you might be wondering, why does this matter? Well, a posterior cervix is pointing towards the back, kind of tucked away, which makes it harder for the baby's head to line up. So that scores a 0. As the cervix moves forward into an anterior position, it's basically getting into perfect alignment for delivery, which is why that score goes up. And last but not least, fetal station. This just tells us how far down the baby's head has dropped into the pelvis. We measure it against the ischial spines, these 2 bony points in the pelvis. Think of the spines as 0 station. If the baby's head is still way up high, it gets a negative number, like -3, which scores a 0. But as the baby descends to or past those spines, the station becomes 0 or positive, and that earns the highest scores, because that baby is on its way out. Okay, deep breath. You've done the exam. You've added up all the points for those 5 components, and you've got a number. But what on earth does that number actually mean? What does it tell us to do? Let's start with the ideal situation. If you get a score of 8 or higher, that is a good, or what we call a favorable Bishop score. So a high score is great news. It tells you the cervix is ripe, it's ready, and an induction is very, very likely to go smoothly. We'd expect it to look a lot like spontaneous labor, with a really high chance of a successful vaginal delivery. Now, what if the score lands somewhere in the middle, say between 5 and 7? This is what we call an intermediate score. Not quite perfect, but not bad either. This middle-of-the-road score is really where clinical judgment becomes so important. It's a bit of a gray area. Depending on everything else that's going on, you might decide, yep, let's go ahead with the induction. Or you might think, let's give the cervix a little boost with some ripening first to improve our odds. And then we have the low scores. Anything 4 or less is considered a poor Bishop score, and it's a clear signal that the cervix is unfavorable or unripe. A low score like this basically gives you your action plan on a silver platter. It's like a big red stop sign for an immediate induction. It's not that you can't induce labor, but it tells you that first, you've got to focus on ripening the cervix to get it ready for the main event.
So let's put it all together now. How do we connect these numbers directly to the decisions and the actions that you're going to take in a real clinical situation?
Just remember, you're not getting this number just for fun. You use this score before inducing labor to figure out the best way to proceed. It guides those critical decisions about cervical ripening, and you can even use it to help track how labor is progressing. Okay, so let's say you do get that low score, 4 or less, and you know the cervix is unfavorable. What do you do next? What tools are in your toolkit to get that cervix ready?
These are your go-to options for cervical ripening. You've got medications like misoprostol or dinoprostone, which use hormones to help soften and open the cervix. And then you have mechanical methods like a Foley catheter balloon, which uses gentle pressure to do the same thing. The goal for all of them is simple: improve that Bishop score before you even think about starting the induction.
And there you have it, the Bishop score, all the way from the 5 components to the final clinical action. But here's the final thought I want to leave you with, especially for your OSCEs. Knowing the numbers is one thing, but can you explain what it means and what the plan is to a patient? That's the real key to mastering this.